Hello everyone. So, as mentioned in a lot of the talks about this various clinical information that represents potentially a more holistic view of the risk of HIE or severe consequences, and I'm applying a machine learning lens to see how this is predictive of that situation. So, broad objective is looking at this maternal and fetal clinical data that we all have readily available in this data set, applying machine learning models to get a risk score of HIE. And this is solely looking at the clinical data, and the later talks that you'll see in this session are focusing on the CTG analysis, which is the common focus. So as briefly mentioned by Dr. Kearney, we're kind of breaking this clinical data into generally two pieces of information: static information, which we know from the beginning of labor, and it remains a constant fact of whether the mother had a prior cesarean in a previous pregnancy. Are there certain maternal diagnoses in the last 12 months that are related, their age, the fetus's age, and so forth. And we have hourly dynamic data. So during each hour, we have like a summary information on the mother's temperature, their vital signs, or how long the labor has been progressing, whether that's through the dilation or just time in labor. But this is not available every hour, and a potentially indicative feature is also the missingness of this data. So we have that as a separate feature, the missingness of like temperature at each hour as well. So the data set as a whole is quite large, and in the static data we are looking at a model which has about 250,000 births. For the dynamic data, we were focusing on just the blood gas available data set because only more recently have we processed the labor progress and information on the non-blood gas available data set, and that hasn't been evaluated as of yet. So two models are just being looked at. So we have this information known before labor and getting a model that would represent a pre-labor risk score, and then both the dynamic in labor hourly features and the static features combined for a hourly in labor risk score. So for the static, we have two broad classes, healthy, and then for unhealthy, that is acidosis, no HIE and HIE, and that's about 240,000 healthy, 3,000 acidosis, 420 HIE. For the dynamic, in the smaller 25,000, that is the breakup. And we were looking at the entire labor. So in terms of number of records, it gets to about 310,000 hourly time points of healthy and 11,000 hourly time points of unhealthy. So for the training, we were looking at a patient-fold, patient-wise 10-fold cross-validation, and we stratified it based on, we have 15 hospitals, so getting a representation of each hospital, breaking it into different lengths of labor, outcome, delivery mode, so each fold has a similar breakdown. And then we tested it on simple decision trees, ensemble random forest classifiers, and the final model that we're using was this thing called random undersampling boosting, which is a good ensemble classifier to deal with this well-known problem of the large class imbalance, and surrogate splits because our data has a lot of missingness. So this surrogate splits is just a simple, if the data is missing, that there are backup options in the decision tree to classify the outcome. So performing in this classification maximum relevance, minimum redundancy, feature selection, these were generally the top static and dynamic features, which were kind of briefly highlighted in the earlier talks, like for instance, diabetes as a risk factor or temperature as a risk factor. One that Kaiser Permanente developed was this thing called the laboratory-based acute physiology score. It's this single score that represents the last 24 hours of vital signs and laboratory results of the mother, which they initially created not for pregnancies, but then it was reapplied here to see if it was a predictive factor. One which is at least commonly reported in the literature as a static risk factor is parity, where if the mother has not given birth before, it is a significant risk factor. But when considering both static and dynamic features together, it is not a relevant feature. It's captured in the other features that is used in the model. And we similarly saw this in previous work on CTG analysis, where adding parity did not improve the performance of the models. So some general just performance metrics. Using just static data and a pre-labor risk score, looking at the larger 250,000 cohort, the performance was about 0.67. But in the more interesting data set, small data set of the blood gas available, where healthy was more like closer to potentially unhealthy, that's why they took blood gases, the performance is a lot lower at 0.59. And then when looking at the hourly risk score, the way this plot is shown is looking at time before delivery, and we set a particular threshold to represent the emergency cesarean rate. So in this smaller data set of blood gas available, the emergency cesarean rate is quite high at 27% for the healthy group, and setting that as the threshold of not exceeding that, then the detection rates of HIE and acidosis no HIE. So HIE is about 51% detection rate 1 hour before delivery, and detection rate of acidosis no HIE is about in the mid-30s, mid to high 30%. This is looking at instantaneous, so looking at just a single hourly record, but in practice you would potentially act upon this decision. So in a simple, when it's first detected that the baby is the fetus is at risk, you carry through with that single decision. This would be the performance metrics, again keeping hold of the fact that we don't want to exceed the observed emergency cesarean rate for healthy babies of 27%. So overall, when looking at least the blood gas available data set, using solely static features only was detecting about 36% of the HIE cases. Using both the static and dynamic features at the 1 hour before delivery was detecting about 51% of them, which compared to which will be presented by Johan, the CTG analysis, it is quite interesting that it does detect a relatively high number without looking at CTG. And one of the future works we want to look at is integrating these features into CTG analysis in our machine learning models, and also answering the question of like, how do these features augment potentially what is a normal CTG and an abnormal CTG. And these are the funding, and thank you very much.